Ladies and gentlemen, we now move ahead to the last presentation of this session. May I invite Professor Ashamurthy. She is currently Head Department of Cardiology at Savitha Medical College from Chennai. Professor Murthy joins us for the next 11 minutes to speak on sleep apnea and cardiovascular disease. To help Professor Murthy be on time, we have a timer straight across. May I request her to pay attention. Over to Professor Ashamurthy.
Good morning and good afternoon, ladies and gentlemen. At the outset, I would like to thank Dr. H.K. Chopra for giving me this wonderful opportunity to address this August gathering in this unique auditorium with the spirituality. Now, the topic is totally different. Please forget about the congenital heart disease and the interventions. The talk is obstructive sleep apnea and heart diseases. This terminology came from Kumbhakarnan, the sleeping giant, the brother of Ravana. When he came for asking a boon, blessing from Brahma, his tongue was tied by the goddess Saraswati. Acting on Indra's request, so instead of asking Indrasana, he asked for a Nidrasana. So he kept on sleeping for the 6 months. So the terminology came oriented from this obstructive sleep apnea, and the importance came a few decades back. What is the importance of in relation to the cardiovascular diseases? The overall view I'm going to discuss on the prevalence, definition, the general hemodynamic effects, the obstructive sleep apnea and all its cardiovascular effects on hypertension, heart failure, atherosclerosis inflammation, arrhythmias and pulmonary hypertension. And what is the management? How do you treat obstructive sleep apnea? What's the definition of it? The apnea is more than 90% of reduction in the tidal volume, which is lasting for more than 10 seconds. Hypopnea, reduction in the tidal volume of 50 to 90%, which is lasting for more than 10 seconds, which is accompanied by more than 3% decrease in the oxygen saturation, or terminated by the arousal from sleep. So you take the apnea, hypoapnea index, which is more than 5. So this is a disorder of obstructive sleep apnea. And how do you calculate the apnea, hypoapnea index? Is by calculating the number of hours of sleep, and then it is normal is 0 to 4. So if it is more than 5, you indicate that it is an obstructive sleep apnea. What are the risk factors encountered? Age, females after menopause, obesity, neck circumference, craniofacial predisposition, and with the family history. Certain racial groups are more prone for this problem, and cardiovascular disease and heart failure. Obstructive sleep apnea, there is a repeated collapse of the pharynx that triggers the apneas during sleep. So how the patient presents? There's patient present with the intermittent hypoxia, so that he awakes for the sleep, awakes for the oxygen. Exaggerated negative intrathoracic pressures, surges in the sympathetic nervous system, increase in the blood pressure, frequent awakenings. So this is the hemodynamic effects. You can see with the narrow pharynx, and at the sleep, there is a loss of pharyngeal dilator muscle tone, which causes a complete partial collapse of the pharyngeal wall. With the result, the patient comes with the apneas and hypoapneas incidences. Now you can see the diagrammatic representation. You can see there is an increase in the venous return, there is an exaggerated negative intrathoracic pressure, and there is an obstructive upper airway. You can see this, and it results into hypoxia, vasoconstriction, increasing the pulmonary arterial pressures. What are the screening tests for the obstructive sleep apnea? The screening tests are Epworth Sleepiness Scale. That is based on there are certain scales in which you assess the snoring, whether how much do you snore, then what is the loudness, and there are various factors which they get a score. Berlian's questionnaires, overnight oximetry, most often used in the clinical practice. So you are the practitioners coming from various states, and you must have encountered so many patients of obstructive sleep apnea. So you can do an oximetry at the night, and you can assess there's a drop in 5 to 10% of saturation. You can immediately say the patient has evidence of obstructive sleep apnea. Now the obstructive sleep apnea, the episodes are more than 5 episodes of apnea or hypopnea per hour of the sleep. Number 2, hypersomnolence, and there is episodes of choking or gasping during the sleep, recurrent awakenings, unfreshing sleep, daytime fatigue, and impaired concentration or memory. The sleep disordered breathing, the basic definition, the central sleep apnea in which you have a idiopathic central sleep apnea syndrome or Cheyne-Stokes breathing. So you have to differentiate between these from the obstructive sleep apnea. What is the mechanism encountered for the obstructive sleep apnea? The mechanism involved is hypoxemia, reoxygenation, hypercapnia, retention of carbon dioxide. There's an increase in the intrathoracic pressures, increased arousal, sleep deprivation, and all these mechanisms are giving rise to sympathetic activation, metabolic dysregulation, left atrial enlargement, and there is endothelial dysregulation, systemic inflammatory reactions. So with the result, what happens? All these factors are going to give rise to, cardiovascular diseases like hypertension, heart failure, arrhythmias, renal diseases, stroke, and myocardial infarction. The patient can come with sudden cardiac death also. So you can see the prevalence of obstructive sleep apnea in stable outpatients with the heart failure. You can see the various data, studies, and you can see that the highest incidence of obstructive sleep apnea has been found in study of patients with the heart failure, Pioneer study in 2009. What are the symptoms encountered with this obstructive sleep apnea? Snoring, excess of daytime sleeplessness, witness apneas, poor memory and concentration, and sometimes the patient can come with a dry throat, morning headache, and nocturia. So on examination, physical examination is defined as a Malemtic class. Malemtic class is the difference between assessing the soft palate from the hard palate, which can be assessed by the dentist, and obesity and thick necks in which there is more than 17 inches in males, females is more than 16, craniofacial anatomy in which there is inferiorly positioned hyoid bone, mandibular insufficiency, increase in the mid-facial height. So these are the various nasal obstruction causes of on the physical examination. And you can see that how the appearance of the normal individual, and you can see the obese patients with the obstructive upper airway. Now these are the various activities I have told you that during the non-REM sleep, there's a decrease in the metabolic rate, sympathetic nervous system. This is normal. But what happens is it is disrupted by the OSA. Now, the effects is that there is a retention of oxygen, there is a decrease in the oxygen tension level, increase in the carbon dioxide, decreases the lung stretch, decrease in stroke volume, decrease in the blood pressure, and arousals. All these factors, that is chemoreceptors, pulmonary stretch receptors, baroreceptors, all this gives rise to increase in the sympathetic nervous system. And all these factors are giving rise to peripheral vasoconstriction. And this peripheral vasoconstriction gives rise to increase in blood pressure, there's a left ventricular afterload, and there's an increase in the heart rate. So this is the endothelial dysfunction. You can see there is evidence of independent link to multiple cardiovascular outcomes like hypertension, stroke, myocardial ischemia, arrhythmias, non-fatal and fatal cardiovascular events, all cause mortality. And you can see the hypertension, about 50% of OSA patients are hypertensive. And 30% of hypertensive patients also have obstructive sleep apnea, which is usually undiagnosed. So mostly these patients come with undiagnosed, but when they come with the symptoms, you have to detect all these associated possibilities. Heart failure, 11 to 37%. Patients with systolic dysfunction had a OSA detected on polysomnography. So this is one of the usual technique, which is, I think, most of the general practitioners are using this to assess obstructive sleep apnea. Now, how do you treat these patients? The patients who come with the history of sudden cardiac death, the role of ICD therapy, and the patients with the obstructive sleep apnea can benefit with the continuous pressure and ventilation therapy, CPAP. You can see that definitely the CPAP also decreases the level of inflammation and decreases the CRP and ESR also. Now, this is one of the example of one patient with obstructive sleep apnea who presented with the unstable angina, and you can see that he has found to be a triple vessel disease, and there was a history of non-obstructive sleep apnea. A triple vessel disease, you can have single vessel disease. So this is, you can see the triple vessel disease in a patient with obstructive sleep apnea. The patient can have single vessel, can have double vessel, can have triple vessel, can have left main equivalent also. So myocardial ischemia and infarction is also one of the common incidents which is found encountered, and you can do the various battery of investigations, do electrocardiogram, do a echocardiogram to assess the LV function, and do the coronary angiogram. You can do CT angiogram also to assess the patient as having, who is a high risk group for the patient with the acute coronary syndrome because of the associated endothelial dysfunction. You can see the incidence of sudden cardiac death in obstructive sleep apnea, and various ventricular arrhythmias which is encountered in patients with obstructive sleep apnea, non-sustained ventricular tachycardia, bradyarrhythmias, second degree AV block, and frequent VPCs, multiple ventricular ectopies can be encountered. So these are the various arrhythmias. Pulmonary hypertension also stands about 16 to 42% of patients with OSA who have a hypertension. So you have to see clinically whether the patient has obesity, poor lung function, and whether how much is the degree of hypoxemia, hypercapnia. Now, how do you manage a patient with obstructive sleep apnea? Obesity is the single most cause of the obstructive sleep apnea. So weight loss is very important. Decrease in the apnea hypopnea index, improved sleep efficiency, decreases snoring, and improves oxygenation and positional apnea. CPAP is one of the very important management of patients with OSA. Proper introduction and education, careful selection of appropriate mask, pressure ramp, bi-level or auto-titrating the device, and oral appliances, and surgical management. Suppose if the patient doesn't get improvement with the medical management or CPAP, then you have to go for surgical correction. What are the unanswered questions of obstructive sleep apnea? Because is it the obstructive sleep apnea is contributing independently, or it is associated phenomena of CAD, congestive heart failure, atrial fibrillation, and stroke? Is hypertension an intermediate step between obstructive sleep apnea, or it is a development of cardiovascular diseases? Does the OSS usually decrease the risk of hypertension and cardiovascular diseases? Is there any long-term mortality benefit of treating patients with CHF who present with CPAP? So these are some of the unanswered questions. And with the concluding round, ladies and gentlemen, without treatment it is dangerous, but it is common, which is usually recognized, treatable, interrelated, and it is quite prevalent. So multiple adverse cardiovascular consequences can be encountered. With this, ladies and gentlemen, I thank you very much for your kind intervention, and I thank the chairpersons, and I thank once again the organizing committee members of WCC for giving me this opportunity. Thank you.
Thank you very much.
One question.
Yeah, there is a question, Professor Murthy, from Dr. Lingam. Yeah.
Anyone? Okay, carry on.
Because, no, it is an associated phenomena. See, those patients who come with the obstructive sleep apnea, if they are high risk, if they are diabetic, hypertensive, you like to investigate the patient. So when you investigate the patient, it may be a correlation. Because I told in my last slide, it is unanswered. Whether it is a consequence of the cardiovascular compound, it is a separate entity. The incidence is at 3 to 5%.
I want to say something here, please. Children also get obstructive sleep apnea. A good number of children get that due to adenoid hypertrophy.
Yes, sir.
It's very easy to recognize and can be dealt with very easily by removing tonsils. Children who snore at night and those who make snoring noise during daytime most likely have hypertrophy of adenoids. In other words, snoring daytime and nighttime is abnormal. They most likely will have obstructive sleep apnea and have all the problems you highlighted today, and it can be dealt with very easily. Thank you very much.
Thank you.
Now,
Thank you very much,
we ran out
Professor
of time. Thank you.
One question, please.
Yes,
Can
sir.
I just say, Dr. Asha, I think this obstructive sleep apnea is being recognized now, and it is mostly 90% obese with snoring, and I think associated hyperlipidemia.
Yeah.
Because I have done a study in those extremely obese patients who cannot even sit,
Yes.
and they come with snoring, and I've done that carotid examination, that carotid intimal thickness is so much
Yeah.
that there are plaques there almost occupying about 75 to 80% of the carotid
Yes, yes,
lumen.
Yeah.
So that also probably leads on to a state of hypoxia.
yes.
And
Because they're obstructing
yes,
the flow of the carotid.
That's right.
Yeah, correct.
So I think now obese people should be
Yeah,
investigated from this point of
Yeah.
view and picked up.
Thank-
Of course, coronary artery disease is an associated
Yeah.
feature.
Thank
Thank you
you.
very
Thank you
much.
Thank
so
you very much,
So thank you very
chairpersons.
much for the three speakers.